Anne Woolfield.
I'm Mel Akerman.
And I'm Carla Pecoraro, and we're your hosts of the Uterine Sound podcast, bringing you up-to-date information on all things O&G. Today, we're talking about red cell antibodies. Checking the blood group and antibodies is one of the first things we do in pregnancy. The phrase O positive, antibody negative just rolls off the tongue. But the second that result comes back as antibody positive, it really throws us. Which antibodies do we worry about? How often do we have to check them? Well, listen in, my friends, and we'll fill you in on everything you need to know. Let's start with the basics. What is a red cell antibody?
Red cell antibodies occur when the immune system is exposed to a red cell antigen that it hasn't seen before. The immune system treats the antigen as foreign and forms antibodies which bind to the antigen and trigger the immune system to destroy it. This is termed red cell alloimmunization or isoimmunization. Isoimmunization can occur if a person is exposed to foreign antigens during a blood transfusion, organ transplant, or more commonly, during pregnancy. Once the body has formed antibodies, it has them for life. Red cell antibodies occur in about 1.2% of pregnancies, but only 0.4% of pregnancies have clinically significant antibodies. Women should be checked for red cell antibodies at booking and again at 28 weeks gestation.
So why do we care about isoimmunization?
Now, as we mentioned last week, the reason we worry about isoimmunization in pregnancy is because of the risk of Haemolytic Disease of the Fetus and Newborn, or HDFN. If a mother has antibodies against a fetal red blood cell antigen, those antibodies can cross the placenta and bind to the antigens on the fetal red blood cells, triggering hemolysis. Once the rate of red cell destruction exceeds the rate of red blood cell production, fetal anaemia occurs. This then results in high drops, high output cardiac failure, and death. Fetal anemia can also lead to neonatal complications, including neonatal jaundice and hyperbilirubinemia. If this is untreated, then the baby can develop kernicterus, sensory neural deficits, or death.
For those of you who aren't paediatricians, let's explain what kernicterus is. Kernicterus is also called chronic bilirubin encephalopathy and is basically a permanent brain injury due to the buildup of bilirubin in the brain. When red blood cells are destroyed, they're first broken down into heme and globin molecules. The heme molecule is further broken down into biliverdin and then bilirubin. Bilirubin is transported to the liver where it is joined with glucuronic acid to become conjugated bilirubin. Conjugated bilirubin is then secreted into bile and the intestines and excreted in feces as urobilinogen. When the rate of hemolysis and production of bilirubin exceeds the ability of the liver to conjugate the bilirubin, you end up with an excess of unconjugated bilirubin. Unconjugated bilirubin can cross the blood-brain barrier and is neurotoxic in high levels. It's this damage to the brain, specifically the basal ganglia, that results in the classic features of kernicterus, chorioathetoid cerebral palsy, gaze palsies, and sensory neural impairment.
Wow, what a physiology lesson. So can that happen to the baby while it's still inside the uterus?
No. So when the baby is in utero, bilirubin is removed by the placenta. It's not until after birth, when the neonatal liver starts processing the bilirubin, that you can start to get the buildup of unconjugated bilirubin.
I've always wondered that. HDFN is actually a really big deal. My dad's a paediatrician and he's done some work in a resource poor setting. His work actually started with kids with disabilities. He found that there are a lot of children who had cerebral palsy from Haemolytic Disease of the Fetus and Newborn with inadequately treated jaundice who ended up with kernicterus and cerebral palsy. Here's some very sad stories of women who were hit in the abdomen by their farm animals or through domestic violence. They had a stillbirth. They were rhesus negative, and thus, as a result, they become isoimmunized, and the next pregnancies were affected by rhesus disease. The work he's done has been to develop an NTD guideline for pregnancy and postpartum and working to assist in the treatment of jaundice.
Didn't your dad also invent some kind of phototherapy device for jaundice? He seems very, very impressive. It's also pretty cool that you've got a connection to someone who's actively trying to reduce this terribly significant disease. On that note, is there anything else we can do to reduce the incidence of HDFN?
Well, by far the best strategy is prevention of isoimmunization in the first place. We spoke about the role of cross-matching blood and administering anti-D for rhesus-negative women in our last episode, and to date, these have been the most effective ways to reduce the incidence of HDFN. Once isoimmunisation has occurred, our options are a bit more limited. One way to prevent HDFN in a woman with known red cell isoimmunisation would be to try and avoid having a baby with the corresponding antigen. This isn't really practical for spontaneous conceptions, but might be a reasonable option for women undergoing assisted reproductive technology. For these women, options include IVF with pre-implantation genetic diagnosis, and with this you can determine the fetal blood group, and you would then only implant those embryos who do not have the corresponding antigen. Obviously, this is only useful if the father is heterozygous rhesus positive. If he is homozygous positive, then all of the babies are going to be affected anyway. Another option would be to use antigen-negative donor sperm, and a third option would be to use a surrogate or gestational carrier. This is where you implant your embryo in a surrogate person who isn't isoimmunized, thus avoiding HDFN. These options obviously aren't practical for everyone, and so in general, our management of red cell isoimmunization involves identifying those at risk, monitoring the titers, and treating anaemia in the fetus or newborn.
Okay, so for those women with isoimmunisation who can't afford to go through IVF or don't want to use donor sperm or a surrogate, how should we counsel them? How likely is it that their babies will develop haemolytic disease of the fetus or newborn?
So the chance of developing HDFN depends on a few things. Firstly, the type of antibody that she has. Secondly, whether the baby carries the corresponding antigen or not. And thirdly, what the antibody titer is. A recent 2019 study found that of 194 women who are isoimmunized with the risk to the baby, 80% had titers in the critical range, 30% had an elevated MCA PSV indicative of fetal anemia, and 25% required at least one intrauterine blood transfusion.
Okay, so Anne mentioned before that the incidence of HDFN depends on the type of antibody. So which antibodies do we need to worry about?
Now, not all antibodies lead to haemolytic disease of the newborn. There are some antibodies that are much more likely to than others, and some that don't cause HDFN at all. Trying to remember which ones are important and which ones aren't can be a little tricky, so we'll try and make it easy for you. Antibodies that have a high risk of causing HDFN include rhesus D, little c plus big E, and KEL. Antibodies that have a moderate risk of causing HDFN include FYA, which is otherwise known as Duffy, big E, big C with little e, JKA, MNS, and ABO. And antibodies that have no risk of causing HDFN include Lewis, I, and P1.
Okay, surely there is a good acronym or mnemonic for this, because it sounds like you just said the alphabet and my brain is fried. So high-risk antibodies were the rhesus antibodies, little c, big D, little c, and big E, and KEL. So the D, E, K are all capitals and the C is in lowercase. I guess you can remember this by thinking little Colin has a big deck.
Well, that's inappropriate, but are you going to forget it? No.
Come on, I challenge you to come up with a better way to remember it.
Well, there's also Lewis lives, Duffy dies, KEL kills.
And you can remember the antibodies that don't cause HDFN by the lip mnemonic, Louis, I, and P1.
How come some antibodies cause a risk but others don't?
So remember the three antibodies that don't cause HDFN are Louis, I, and P1 antibodies, the lip antibodies. Firstly, fetal red blood cells don't have Louis antigens. These actually develop later in childhood, and because of this, it doesn't really matter if Louis antibodies do cross the placenta, because there are no antigens for them to bind to, and therefore they can't cause any harm. Louis antibodies are also typically IgM antibodies. If you remember from our last episode on anti-D, IgM antibodies are big and so they can't cross the placenta, whereas IgG antibodies are little and they do. If the antibodies can't cross the placenta, then they can't bind to fetal red blood cells, and therefore there is no risk to the baby. P1 and I antibodies are also IgM, and therefore the baby cannot be affected.
Why do they even report on these antibodies if they don't matter?
Well, while they don't matter for HDFN, there are still implications for having antibodies. For example, if the woman requires a blood transfusion, you would need to make sure the blood she is given is compatible. If she is given blood that contains the antigens to which she has developed antibodies, then there is going to be a transfusion reaction. Remember, cross-matching can also take longer in the presence of antibodies, and in some cases, the blood bank may even need to order incompatible blood from the Red Cross. So you really need to know about these antibodies in advance.
Yeah, okay, that's such a good point. All right, so let's talk about what we do if a woman's antibody screen is positive. We've already mentioned that we want to know what type of antibody she has so we can determine the risk of HDFN. High-risk antibodies are little c, big D, little c plus big E, and KEL. Moderate risk are Duffy, JKA, big E, big C, little e, and big M and S, and ABO. And low risk are Lewis, I, and P1. What's our next step?
The next step is to determine the fetal blood group to work out whether the baby carries the corresponding antigen and is therefore at risk of haemolytic disease or not. If the baby is antigen negative, then there is no risk and you can manage the pregnancy as normal. There are two ways to determine the fetal blood group. The first is through inference, so determining the paternal blood group and then working out the baby's blood group from that. If the father is antigen negative, then the baby will definitely be antigen negative, and therefore there's no risk of HDFN. If the father is rhesus positive, then it depends on whether he is heterozygous or homozygous positive. If he is homozygous positive, the baby will definitely be antigen positive. If he is heterozygous positive, there's a 50% chance of the baby being antigen positive and a 50% chance of the baby being antigen negative. Just remember, though, that there's about a 3% chance that who you think is the father of the baby is not actually the baby's dad. So always be cautious when using this approach.
The other way to determine fetal rhesus status is through cell-free fetal DNA. Cell-free DNA can be used to determine the rhesus antigens, little c, big D, big E, and KEL. Unfortunately, it's not yet useful for any other antibodies. Ideally, cell-free DNA for rhesus D typing should be done after 11 weeks because below this, it's much less accurate. Now remember, cell-free DNA is not perfect. There's a 3 in 1,000 risk of a false negative result, meaning the test comes back saying the baby is rhesus negative and therefore not at risk, when actually the baby is rhesus positive and is at risk. Another limitation of cell-free DNA is in the case of twins. Monozygotic twins will have the same blood group, but dizygotic twins may not. Cell-free DNA cannot tell the difference between blood groups in dizygotic twins.
We mentioned last week that using cell-free DNA to avoid anti-D in rhesus-negative women with rhesus-negative babies might be an option. And while this is recommended in the latest guidelines, currently that test is not available for women until it's approved by the government. To our understanding, there is a hospital program in Western Australia and potentially Melbourne where they are trying out the cell-free DNA for this purpose, but you do need to enroll and actually have access to the test. At this stage, women can't choose to have testing done and pay for it themselves. Currently, cell-free DNA for fetal blood group is only performed in a Queensland laboratory for very specific indications, which do include rhesus isoimmunisation. This means that every cell-free DNA test in Australia for this purpose is sent to the Queensland lab.
Amniocentesis can also be performed to determine the fetal blood type, and this might be used for other antigens, especially if fetal anemia is suspected. Genotyping can generally be done from 15 weeks for all antibodies except for KEL. KEL genotyping needs to be done from 20 weeks because there's a risk of a false negative result if performed earlier in the pregnancy. Ideally, you would avoid chorionic villus sampling because it has the potential to increase the maternal antibody titer.
Okay, so we've determined what antibodies the mother has and whether they pose a risk to the baby or not. Next, we've determined the baby's blood type. Babies who are negative for the antigen are off the hook, and those pregnancies can be managed routinely. What do we do when the baby is positive for the antigen?
Once we know the fetal blood type and possible risk to the baby, then we need to start monitoring antibody titers. Antibody titers basically quantify the amount of antibody present in the maternal circulation. In general, the higher the titer, the higher the risk to the baby. For our high-risk antibodies, so big D, big K or KEL, little c and little c plus E, we would perform titers 4 weekly from 18 to 28 weeks, and then fortnightly until delivery. For all other antibodies, the titer only needs to be repeated at 28 weeks. Now, this is only if the titer is stable. If at any point it looks like the titers are rising, then you would need to increase the frequency to fortnightly. In most pregnancies, the titer will remain low and no further intervention is needed, but for some, the titers will rise. Once the titers reach a critical threshold, the woman should be referred to maternal fetal medicine for weekly ultrasound scans. The critical titers vary depending on the antibody. So for anti-D, the critical titer is 1 in 32. For anti-Cal, the cutoff is 1 in 4, or essentially as soon as it's detected. Anti-Cal is the only antibody that doesn't play by the rules. While most antibodies need a high titer to cause harm, anti-Cal can cause HDFN at any titer. So we need to monitor these babies closely from the start.
I've also heard about antibody quantitation. What's the difference between titers and quantitation?
So, antibody titers are performed using an indirect agglutination test. Basically, maternal plasma is diluted and incubated with red cells, and the agglutination reaction is measured. Results are typically given as the highest dilution that results in a positive reaction. Quantitation is measured by continuous flow analyzer technique or by flow cytometry. You might remember we went into the science of flow cytometry in our last episode. In Australia, quantitation is only performed in Sydney and Perth laboratories 2 to 3 days per week, meaning that most hospitals will need to send their specimens to these labs to get it done. Turnaround time can take about 5 to 7 days from the time the lab receives the sample, and so quantification can be a little less timely than performing titers. Now, there's a bit of debate about whether we should be monitoring antibody levels using titers or quantification. Some centres advocate monitoring for both, whereas others just do titers. At our hospital and most other hospitals in Queensland, we would do a quantitation for anti-D or anti-c antibodies only once the titer becomes critical at 1 in 32. A major argument for antibody quantitation is that it has a higher sensitivity and a better predictive value for fetal anaemia than titers alone. Although it does take a while to get back, so sometimes clinical decisions might need to be made on the titer. We suggest following your local policy under guidance from your maternal fetal medicine department.
If you are using antibody quantification rather than or in addition to titers, then you need to be aware of the critical levels for referral. For anti-D, the critical quantification is greater than 4 international units per mil, with a risk of severe HDFN at 15 international units per mil. For anti-c, the critical quantification is greater than 7.5, with a risk of severe HDFN at 30.
Okay, so once the antibody titer or quantitation has a critical level, we refer to MFM for weekly Dopplers of the MCA PSV. How is that helpful?
Ultrasound monitoring of the middle cerebral artery peak systolic velocity, or MCA PSV, is a good way to predict fetal anemia. The test has a 100% sensitivity in the prediction of moderate to severe anemia and is used to stratify which babies need fetal blood sampling and intrauterine transfusion. When a baby has fetal anemia, there is reduced blood viscosity and increased cardiac output, which results in increased blood flow to the fetal brain and therefore an increased MCA PSV. It's important to note that the MCA PSV is not perfect though. Although it won't miss any cases of fetal anemia, it does have about a 12% false positive rate. This means that some babies might undergo invasive fetal blood sampling unnecessarily, which carries a 1 to 2% rate of fetal loss. MCA PSV is also less accurate after 35 weeks gestation and also after intrauterine transfusion. MCA PSV should be performed weekly once the critical titer is reached or if there is a history of HDFN in a previous pregnancy.
Okay, so let's refresh our memories on the indications for weekly monitoring with MCA PSV. Indications include anti-D with a titer of more than 1 in 32 or quantification of more than 4 international units per mil from 22 weeks. Anti-c with a titer of greater than 1 in 32 or quantification of greater than 7.5 international units per mil from 22 weeks. Other antibodies with a titer of greater than 1 in 32 from 22 weeks, and anti-Cal once detected from 16 weeks. Once the MCA PSV hits the threshold of 1.5 multiples of the median, then you need to refer onto MFM for further investigation and treatment.
Did you know that we've only been using ultrasound monitoring of the MCA PSV to predict fetal anemia since the early 2000s? Before that, we used to do serial amniocentesis. Basically, bilirubin absorbs light at a certain wavelength, so you have to use that to analyse amniotic fluid and estimate the degree of fetal hemolysis. This was called Delta OD450. And for those of you practicing for your Ranscott MCQs may have seen this pop up a few times. This process was invented by Dr. Albert William Lilly, who actually performed the first successful intrauterine blood transfusion for rhesus isoimmunisation. And you'll never guess where he's from.
Oh my God, please be Australia.
Close enough. He's actually from New Zealand. We've somehow managed to come across yet another amazing person from Australia and New Zealand.
Woohoo!
I've also heard that you can use MRI to assess a fetal anemia by assessing the fetal hematocrit. It's more specific than ultrasound, which could be helpful at later gestations where the MCA PSV tends to have a higher false positive rate. At the moment, though, MRI is quite expensive, and it's not always easy to get an MRI when you want one. So for now, it's not routine practice. But who knows? Maybe this is something we could use in the future.
Okay, so where are we at so far? We've got a mum with anti-D. We've confirmed the baby is rhesus positive and therefore is at risk of being affected. We've been monitoring titers 4 weekly from 18 weeks. We've hit the critical threshold of 1 in 32 or a quantification of greater than 4 international units per mil. And now we've referred for weekly MCA PSV from 22 weeks. Once that hits the threshold of 1.5 multiples of the median, then what do we do?
Well, we refer to MFM, of course. There's actually a few reasons why we might want to refer someone to MFM in the context of red cell alloimmunization. These are definitely worth remembering and can be broken up into history, titers, and ultrasound findings. History-based indications for referral include history of unexplained severe neonatal jaundice, history of neonatal anemia requiring transfusion, or a history of hemolytic disease of the fetus or newborn. Titer-based indications include antibody titer or quantification over the critical threshold, or a rising antibody titer quantification. Ultrasound-based indications for referral include if the MCA PSV is greater than 1.5 mOMs, or ultrasound evidence of hydrops or anemia like skin edema, cardiomegaly, or polyhydramnios.
Once you refer to MFM, the next step is to perform fetal blood sampling to confirm the level of fetal anemia and determine whether an intrauterine blood transfusion is needed. These steps are usually done at the same time. Fetal blood sampling can be performed between 18 to 35 weeks if there is ultrasound evidence of fetal anemia or hydrops. Before 18 weeks, the umbilical cord is quite difficult to visualize, and fetal blood sampling and transfusion is incredibly difficult. After 35 weeks, intrauterine transfusion is considered riskier than delivery, followed by postnatal transfusion. So if the MCA PSV is greater than 1.5 moms at 35 weeks or greater, then this would warrant delivery without fetal blood sampling to check the fetal hemoglobin. Fetal blood sampling is performed via the fetal intrahepatic vein or by cordocentesis at the level of the umbilical vein at its cord insertion at the placenta. In extreme circumstances, you can also puncture the heart to obtain a sample. A small amount of fetal blood is drawn and assessed immediately for anemia, which usually involves someone running really quickly down to the lab to get the result. If the hematocrit is less than 30% or the hemoglobin is more than 2 standard deviations below the mean, intrauterine transfusion is performed at the same time.
Now, fetal blood sampling is not risk-free. It does carry a risk of fetal loss at 1 to 2%, and if the fetus is hydropic, then this rate is even higher. However, if a fetal blood sample or transfusion is not performed, then the risk of stillbirth is much higher than that. Once the fetus is found to be anemic, it will typically need serial intrauterine blood transfusions. You can estimate the timing of the next transfusion by predicting a drop of fetal hemoglobin of 0.3 grams per deciliter per day. Although once you've done 2 transfusions, you can estimate the timing by the rate of fall in hemoglobin between those 2 transfusions. Blood transfusions are typically done through the umbilical cord or the fetal intrahepatic vein. However, you can also perform an intraperitoneal transfusion in early gestations, even before 20 weeks, which has a lower risk of procedure-related complications than intravascular transfusion. Performing the blood transfusion via the intrahepatic route with fetal paralysis can reduce the rate of complications and perinatal loss. Complications to look out for include cord hematoma, vasospasm, fetal bradycardia, abruption, exsanguination from the fetal puncture site, intrauterine infection, and ruptured membranes.
Now, it's important to know that there are certain requirements for blood used in an intrauterine transfusion. It either needs to be O or ABO compatible with the fetus. It needs to be KEL negative, CMV negative, and obviously negative for the antigens corresponding to the maternal antibodies. The plasma should be reduced to increase the hematocrit to 0.7 to 0.85. It should be irradiated to reduce the risk of graft versus host disease. Oh, and it should also be less than 5 days old and transfused within 24 hours of irradiation. Because we can sometimes be looking for a rare blood type, the Red Cross may need to call up donors or order the blood in. So if you think you might need to do an intrauterine transfusion, then you need to be organising this stuff in advance. Okay, now let's talk timing of delivery. When should these babies be delivered?
In pregnancies complicated by alloimmunisation in which no intrauterine transfusion was performed and the MCA PSV remains less than 1.5 moms, the recommendation is to deliver between 37 to 38 weeks gestation. In pregnancies with alloimmunisation in which no intrauterine transfusion was performed and the MCA PSV reaches over 1.5 moms after 35 weeks, the recommendation is to deliver immediately and treat the newborn for HDFN rather than doing an intrauterine transfusion. Remember, this is because it's sometimes safer to just do a postnatal transfusion. In pregnancies in which an intrauterine transfusion was performed, it's important to time the delivery to ensure the baby is not anemic at birth. Typically, you would deliver 3 weeks after the last transfusion and somewhere between 37 to 38 weeks gestation, but usually the timing is up to the maternal fetal medicine department.
All right, Carla, since you've done peds way more recently than we have, what should we do after the baby's born?
So, once the baby is born, we should collect cord blood for blood group and antibodies to confirm the fetal blood group, for hemoglobin and bilirubin levels to detect the level of anaemia, and to determine the need for transfusion or phototherapy, and perform a direct antiglobulin test. Maternal antibodies persist for up to 6 months, leading to ongoing red blood cell destruction, so we need to monitor the baby for signs of jaundice and anaemia. Top-up transfusions will be needed in 4 out of 5 neonates with HDFN until late postpartum anemia resolves. Late postpartum anemia can occur because of persistence of antibodies, or if there have been multiple intrauterine transfusions, because these can suppress erythropoiesis. The baby should also be fed regularly to reduce the risk of dehydration, which can also lead to increased jaundice. And it's important that we treat neonatal jaundice with phototherapy or exchange transfusion to prevent kernicterus.
And what's the prognosis in subsequent pregnancies?
For anti-D antibodies, HDFN tends to become more severe with each subsequent pregnancy. It also tends to occur earlier. It can be useful to remember the rule of 10. The need for intervention in the current pregnancy is likely to occur up to 10 weeks earlier than it was in the previous affected pregnancy. This is likely because of the fetal-maternal hemorrhage that occurs at each birth, which increases the maternal antibody response. Because severe anemia typically occurs at earlier gestations than the previous pregnancy, subsequent pregnancies should be managed with MCA PSV monitoring from 16 weeks gestation. If you required an intrauterine transfusion, had high drops preterm birth because of severe fetal anemia or neonatal exchange transfusion, then you can expect to develop severe fetal anemia in subsequent pregnancies.
Okay, quick summary of what to do if you have red cell isoimmunisation. Firstly, determine the baby's blood group. You can do this through partner blood group and phenotype or the NIPT. Next, do serial antibody titers every 4 weeks from 18 weeks until 28 weeks, and then fortnightly. If the titers are rising, if you reach the critical thresholds, or if you have KEL antibodies, then refer to MFM for weekly MCA PSV to monitor for fetal anemia. The critical titers are typically 1 in 32, with a quantitation of greater than 4 international units per mil for anti-D and 7.5 international units for anti-C. If the MCA PSV is greater than 1.5 moms, or if there is ultrasound evidence of high drops, then arrange fetal blood sampling. Fetal blood sampling and intrauterine transfusion should be done at the same time if needed. Delivery is usually via induction at 37 to 38 weeks, but if the baby is having transfusions, you need to time delivery around that. Postnatally, send cord blood for a group and hold, DAT, hemoglobin and bilirubin levels. Monitor the neonate for jaundice and anemia. Regularly feed the baby. treat jaundice with phototherapy or exchange transfusions, and watch for late onset anemia. Thank goodness for paediatricians.
All right, one thing I want us to get into is IVIG. We had an isoimmunised patient recently, and our MFM team were talking about giving IVIG. What is the role of IVIG here?
So the only current role of IVIG is to allow deferral of the first fetal blood sampling for severe early onset red cell isoimmunisation. IVIG is thought to work by reducing maternal antibody production and blocking the transport of IgG antibodies across the placenta. It can't prevent HDFN, but it may maintain the fetal hematocrit above life-threatening levels long enough to achieve a gestational age when intrauterine transfusion is technically feasible and less likely to be associated with fetal death. The risk of fetal loss from intrauterine transfusion before 20 weeks is about 5 to 8%, compared to 1 to 2% above 20 weeks. The typical dose is about 0.7 to 2 grams per kilogram per week, and it's given until a fetus could be safely transfused. Weekly IVIG has been shown to delay the development of severe anemia in early gestation by about 15 to 25 days, resulting in less high drops and a technically easier and less hazardous procedure when intrauterine transfusion is required. It doesn't stop the HDFN or cure it though, it just delays the gestation at which you need your first transfusion, which could be the difference between doing an incredibly difficult fetal blood sampling and transfusion at an early gestation versus doing it at a higher gestation where it is easier and much less likely to result in fetal death.
I've heard that they're also looking into developing monoclonal antibodies to block the transfer of IgG across the placenta. There is one called nipocalimab, which I'm pretty sure is currently in the middle of a phase 2 clinical trial. Think of how good it would be if we could stop pathogenic maternal IgG from getting to the baby. It would be so useful for all the other immune conditions, like fetal neonatal alloimmune thrombocytopenia, autoimmune congenital heart block, or neonatal thyrotoxicosis.
Yeah, absolutely. I do wonder what the effect of these antibodies would be on the rates of neonatal infection, though. Like, don't maternal antibodies play a huge role in neonatal immunity? Isn't that the whole point of getting pertussis and the flu vaccine pregnancy? Surely they'll need to work out how to get the antibody to just block the pathogenic IgG and not the IgGs that we actually do want to cross the placenta. I'm so glad that there are much smarter people than us working on this.
It's also important that we start looking beyond survival and to improving the long-term outcomes of these babies. Survival from HDFN is about 88%. Of those survivors, approximately 2.4% have cerebral palsy and 6% have neurodevelopmental impairment, which might include severe developmental delay, deafness, blindness. A lot of this is associated with high drops and neonatal prematurity. It's really hard to tell whether these outcomes are a result of the HDFN, the treatment with intrauterine blood transfusions, or both. The next steps we will need to look at is how to improve the long-term outcomes for these little babies.
Okay, one final topic before we wrap up for the week. Anti-KEL antibodies. This always comes up in an exam. What is the difference between anti-KEL alloimmunization and anti-D alloimmunization?
Well, firstly, let's think about how these antibodies develop. Anti-D antibodies are most likely to occur after sensitization in a previous pregnancy. Anti-KEL antibodies are more likely to develop as a result of blood transfusions. Secondly, let's think about the effect of the antibodies on the baby. KEL antibodies produce hemolysis in the same way that anti-D and other antibodies do, but they also suppress erythropoiesis and cause immune destruction of early erythroid progenitor cells. This leads to an earlier and more severe anemia. Because KEL antibodies cause less hemolysis in general, hyperbilirubinemia is also not a prominent feature. Thirdly, the severity of the disease is not related to the titer, and so pregnancies with anti-KEL antibodies should be referred to MFM for weekly MCA PSV from 16 weeks as soon as anti-KEL antibodies are detected. This is unlike anti-D, where you would monitor the titers monthly until 28 weeks and fortnightly from then on, and refer once the critical titer of 1 in 32 has been reached. Finally, we think about recurrence. With anti-D, the severity of fetal anemia and HDFN worsens with each subsequent pregnancy. Remember Anne's rule of tens. However, with anti-KEL, past obstetric history is not predictive of disease severity in subsequent pregnancies.
And don't worry, everyone, we will summarize these beautifully and nicely for you in our weekly summary on Instagram.
And thanks for listening to this week's episode of the Uterine Sound podcast. If you have any comments or feedback, please reach out to us. Our website is theuterinesound.com, Facebook or Instagram at theuterinesound, or email us at theuterinesound@gmail.com. We'll speak to you next time.